This is the fourth recording for Chapter 11. We're talking about inhaled medications. Oxygen is definitely the most commonly used medication in the pre-hospital setting. Every single cell in the body needs oxygen to survive, especially those in the heart and the brain. Oxygen should be administered when a patient is not breathing, they're having problems breathing, or they're complaining of being short of breath. Since remember, shortness of breath is a symptom, since we can't definitively measure it. Oxygen is generally administered two different ways in the field, though we have other options, but non-rebreather masks typically sent anywhere from 10 to 15 liters per minute. This is the preferred method for patients that really actually need oxygen. It can provide up to 90% inspired oxygen. The other way is via nasal cannula. You set it anywhere from 2 to 6 liters per minute. This is going to be for those patients that can't tolerate a non-rebreathing mask. Some people get extremely claustrophobic when you put a mask on their face. So we'll end up giving it this way. Or for those that just need low levels of oxygen, just to kind of assist them. This can provide up to 44% inspired oxygen if the flow meter is set to 6. If the patient is not breathing or breathing completely inadequately, we'll end up using a bag valve mask and set that at 15 liters per minute. And that'll deliver the 90%, but we'll actually be squeezing the bag to breathe for the patient. Make sure that you don't have any open flame near oxygen. I think that goes without saying, but just to remind you. Other inhaled medications, metered dose inhalers and nebulizers. These administer liquid medications that have been turned into a fine mist, generally by the flow of oxygen or air through it. The medication is atomized into teeny tiny little particles that are breathed into the lung, delivered to the alveoli, and then cross over into the bloodstream. So you get very, very fast absorption because blood flow to the alveoli is very high. This is pretty close to IV medications, which are put directly into the bloodstream. Not quite as fast, but definitely approaching that. It's a relatively easy route of access for the patient. They're also commonly used because they're extremely convenient and they're very, very portable. Disadvantages. Patients need to be cooperative and in control of their breathing. You can't use it on an unconscious patient. So that makes it a little bit more difficult. You do have a couple of different ways to administer these types of medications. You have the metered dose inhaler, or you have a small volume nebulizer. And the small volume nebulizer is actually what is shown up on the screen right now. So these are for respiratory conditions that are not severe enough to require epinephrine, but do need some sort of medication to kind of help open them up. We typically call them bronchodilators. So chemically, bronchodilators are, we'll say, cousins to epinephrine. So kind of achieve similar effects, but not really identical in their makeup. The metered dose inhaler, you have to have some coordination in order to administer it, and it could be hard to get the medication where it needs to go if the patient is having a hard time breathing. You need to aim properly and spray just as your patient takes a very big inhale. And we typically ask them to hold their breath for a couple of seconds afterwards so they don't just breathe the medication back out. You can use a spacer, which is just an adapter that goes on the end of the inhaler housing itself. It has an opening at one end that only fits the inhaler, and then it has a mouthpiece on the other end. It's really hard to mix up which goes where. The patient sprays the prescribed dose into the chamber and then breathes it in and out until the entirety of the mist has been inhaled. Spacer devices are really helpful in children or those that have recently gotten their inhaler and they don't quite know how to use it appropriately. we typically don't carry around a spacer with us, or at least I never have on any of my services. Instead, we're going to use the small volume nebulizers. They take longer to deliver the medication because they have to breathe it in completely. They definitely require an external oxygen source or air source. However, they can be more effective than the metered dose inhaler because if they have respiratory distress already, they don't have to take one big breath in. They get medication little by little as they're breathing in and out. This can be used while a patient is on CPAP or when you're bagging them using a BVM. You can put it right in line. You can even put it in line with a non-rebreather mask if your patient needs a little bit higher concentration of oxygen than what they're going to get through this mouthpiece. You can actually pull off the bag and snap this right into the bottom of that non-rebreather. When you are assisting a patient with a small volume nebulizer, make sure that you obtain medical control if you need it, if it's not already in your standing protocols. Check the correct medication and expiration date. The little tubes that the albuterol comes in looks very similar to sterile saline, excuse me. So you got to make sure that you actually have the medication and not just plain saline. That's not going to help them. You're going to put the medication into the nebulizer reservoir and assemble the device. It does come disassembled in a little package, and I guarantee you the first time that you go to put this thing together, you're going to be like trying to put Tinker Toys together and smashing it because you think you know exactly how it goes, and you will find out very quickly that you have to think about it, especially if it's 3 o'clock in the morning and you haven't slept all night. You want to attach the tubing of the nebulizer on the bottom. Looks just like oxygen tubing. You're going to connect that to either a nebulizing machine or more possibly to an oxygen tank itself at 6 to 8 liters per minute. Even if you have this attached to a BVM or you have this attached to a non-rebreather, you still cannot set it too high. If you have it set too high, that tree is what we call the little green piece that you often attach oxygen tubing to. It's going to just keep blowing it off of that because the pressure's too high for the tubing. If that happens, go ahead and take your flow meter down just a little bit and try reconnecting that tubing. You're going to place the nebulizer in the mouth and instruct the patient to breathe until the medication is completely gone. Typically, it takes about 5 minutes to empty a reservoir on a nebulizer. And then just like everything else, you're going to reassess and you're going to document how your patient reacts to that medication. Some patients do use rescue inhalers that, this is not something they take every day. It's just when things get rough. These are also cousins of epinephrine that produce fewer side effects. It acts more specifically, meaning certain receptors than epinephrine does on the bronchi of the lungs, causing them to dilate, but it has less effect on the heart. Examples, metoprolol and albuterol. Respiratory patients may also use a maintenance or controller inhaler. This is slow acting and they take it on a regular basis, generally every day, but they're not useful for patients that suffer acute respiratory distress. So if somebody's on an inhaler every single day and they have a sudden attack, taking their everyday medication probably not going to do a whole lot for them because it absorbs so slowly. Examples of this, you have Flovent, Pulmicort, Qvar, those types of things. And keep in mind that your patient may be prescribed several different types of metered dose inhalers at once. So they may have that every day that I take, it's got a steroid in it, and then they may have that rescue inhaler as well. Ask them how many times they've used each one so that you have an idea of how much med is running around in your patient system. So patient assessment includes finding out what medications the patient is taking, which may provide you with some vital clues as to the patient's condition. It might help guide your treatment, can be extremely useful to the emergency department physician because it gives them more history and background into what's going on with the patient and keeps them from giving different medications that may not help the patient, might interact with the drugs that they've got. And it can help you determine if the patient has a chronic or underlying condition when they can't tell you their medical history. So if I say, do you have any past medical history? And they say no, and I'm like, well, do you take any medications every day for anything? They're like, oh yeah, well, I take a high blood pressure pill and I take a glucose pill for my diabetes. And I'm like, okay, you do have medication or medical history. They sometimes don't correlate that. You want to discover what the patient takes and transport, normally just a list of them. They say transport the medications to the emergency department, but they often don't want to deal with a whole bunch of pills because now they're responsible for it. A list generally is going to be better than anything. And then again, ask about all medications, over the counter, herbals, vitamins, everything. Medication errors. This is an inappropriate use of a medication that could lead to patient harm. It doesn't necessarily always lead to patient harm. This could include incorrect communication of a dose or the actual administration of an incorrect dose. This could be administration of a medication that is outside one's scope of practice. So you as an EMT have a very limited number of medications that you can actually use in the field. So if you start going off of that list, they can end up getting in big time trouble. Knowledge-based errors, so choosing the wrong medication to administer, and then a skills-based error using incorrect equipment or an incorrect procedure for administering a medication. If you actually report this, and you definitely should, we make mistakes, okay? But by reporting it and kind of talking about the situation that led you to make this medication error, you can actually help minimize somebody else doing the same thing. So when you make a medication error, you want to provide any appropriate patient care that's required first and foremost. Notify medical control as quickly as possible. You'll have a local protocol that talks about medication errors. So follow that. Document the incident thoroughly, accurately, and honestly. And then talk with your partner, your supervisor, or your med director, because this is an opportunity for you to learn. And you can identify areas to target with quality improvement. We always want to improve ourselves as a clinician and then the care that we provide to our patients. You can do a couple of things that minimize the chances of a med error. Make sure that you have sufficient lighting so that you can adequately read the label on the medication. Make sure that your equipment is organized and where it's supposed to be. You'll do this during rig checks before you even get in and respond to a patient. Try and limit your distractions so that you're paying attention to what you're supposed to be paying attention to. You may need to use a cheat sheet so that you remember all the crucial steps. And then always before you administer to your patient, just take a quick second and say, why am I doing this? What am I hoping to achieve to make sure that you're giving that correct medication? This is it for chapter 11. We'll go on with chapter 12 in the next recording.